Hello, my name is Victoria Castillo. I'm a fourth-year medical student at Rutgers Robert Wood Johnson Medical School. In this video, we are going to dive into the topic of external ventricular drainage and intracranial pressure monitoring. This video is rated MS for medical students due to basic concepts, clear language, and case-based examples. Medical student participation is advised. We do not have any relevant financial conflicts to disclose. As always, the case presented in this talk was modified for teaching purposes. This is a complicated topic, so decisions regarding intracranial monitoring and cerebrospinal fluid drainage must be individualized. Patients with elevated intracranial pressure are usually treated by a multidisciplinary team of specialists. We will start by introducing a case of a patient who is at risk for elevated intracranial pressure. Then we'll discuss major indications for intracranial pressure monitoring. After deciding to monitor, we need to understand the four major monitor types with their advantages and disadvantages. And then focus on the gold standard of monitoring, the external ventricular drain, or EVD. After a review of intracranial physiology and cerebral autoregulation, we will discuss pressure monitoring and the early steps to addressing elevated intracranial pressure. And we will conclude with a review of external ventricular drainage complications and the approach to weaning and removal. You can use the chapter markers below to jump between sections. Let's begin with a case. Our patient is a 54-year-old female with history of hypertension and intermittent tobacco use, but also atrial fibrillation for which she has been anticoagulated with a factor X inhibitor, apixaban. She comes to the emergency department with a sudden debilitating headache, a thunderclap headache. She describes it as the worst pain she's ever felt in her life. She admits to photophobia and one episode of emesis before arriving to the emergency department. She denies any family history of aneurysms or recent trauma. On initial evaluation, blood pressure is elevated. Remaining vitals are normal. She is drowsy, but easily arousable to voice. When awake, she is oriented to person, place, and time, and follows commands. She appears to be in distress from head pain. There are no pupillary abnormalities, lacrimation, salivation, eyelid edema, or conjunctival injection. Focal neurological deficits are absent. What is the next best diagnostic study? Naturally, you do what any neurologist would do after hearing worst headache of life with emesis. You get a non-contrast head CT. And here it is. 3 representative axial slices through the pons, midbrain, and basal ganglia. There is extensive hyperdensity in the Sylvian fissures, interpeduncular cisterns, and interhemispheric fissure. These hyperdensities are within the subarachnoid space. So, this is diffuse subarachnoid hemorrhage. The temporal horns of lateral ventricles are dilated, which is an early sign of hydrocephalus. CT angiogram of the head with contrast was also done. Here is a sagittal maximal intensity projection. Vertebral artery, basilar artery, internal carotid artery, anterior cerebral arteries. This patient has a right supraclinoid ICA aneurysm that likely ruptured and caused the hemorrhage. You order and administer 4-factor prothrombin complex concentrate to emergently reverse her apixaban. Calcium channel blocker nicardipine is being infused intravenously, which is maintaining her blood pressure at our goal of less than 150 millimeters mercury. Currently, there is no evidence of intracranial pressure crisis, But you saw on that CT that hydrocephalus is brewing, so you know that this patient is unstable and promptly sent her up to the neurocritical care unit. So, our 54-year-old woman with an aneurysmal subarachnoid hemorrhage, because of a ruptured right supraclinoid ICA aneurysm, is now in the ICU. Anticoagulation has been reversed and blood pressure is controlled. But there is evidence of early hydrocephalus, and our patient is gradually becoming more and more drowsy. She can hardly keep her eyes open and talk to you, but still her Glasgow Coma Scale score is 14, 3, 5, 6. Now your attending turns to you and asks, do you want to put in an ICP monitor? Why? Here we go. Let's review indications for ICP monitoring. Indications for ICP monitoring remain challenging to this day. The core indication is an acute injury causing mass effect. Mass effect should be symptomatic, as in causing signs and symptoms of elevated intracranial pressure. For example, worsening headaches, nausea, vomiting, lethargy, and papilledema in a responsive patient, or posturing and anisocoria in a comatose patient, where there is serious concern for herniation. And there should be reasonable neurological baseline warranting such aggressive intervention. Basically, for benefits of an ICP monitor to exceed risks, at minimum, a patient with reasonable baseline has to have clinically relevant elevated intracranial pressure. Speaking of acute injury causing mass effect, certain situations are more likely to result in an intracranial hypertension and would make your threshold for placing an ICP monitor much lower. These include subarachnoid hemorrhage and intraventricular hemorrhage, where the risk of hydrocephalus is higher, acute hydrocephalus of other causes like meningitis or a mass lesion obstructing the ventricular system, and severe global cerebral edema, which happens in the setting of severe traumatic brain injury. And speaking of clinical signs of elevated intracranial pressure, the degree of neurological injury can be grossly measured by the commonly used Glasgow Coma Scale. What's a Glasgow Coma Scale? There are 3 domains: best eye response, best verbal response, and best motor response. Patients with mild to moderate injury open their eyes spontaneously or to verbal command, and are at worst confused and using inappropriate words in response to questions. They may also move their limbs to command or show evidence of localizing painful stimuli. They touch or withdraw the limbs that receive the noxious stimulus. Our patient opens her eyes to verbal command, so she gets 3 points. When awake, she is oriented and obeys commands. 5 points for verbal and 6 points for motor. 3 plus 5 plus 6 equals 14. Severely injured patients only open their eyes to painful stimuli or have no eye opening at all. Their verbal response is either incomprehensible or non-existent, and motor responses are either absent or limited to withdrawal, flexion, or extensor posturing. If you add up the points, a severely injured patient would get a GCS score of 8 or less. Those are the patients that would be considered for intracranial pressure monitoring. Keep in mind, patient may not be able to protect their airway and they may need to be intubated. But thankfully, that's not our case. The score is not an absolute cutoff, but more of a rough guideline. So now, knowing all of that, what are you going to tell your attending? Does the patient meet criteria for an ICP monitor? If you guessed yes because you know the whole point of this video is to teach you about ICP monitoring, then you missed the point of the exercise, but I admire you gaming the system. Now, if you said yes, but it wasn't a guess, then explain your decision. Our patient's aneurysmal subarachnoid hemorrhage is causing hydrocephalus. The hydrocephalus is likely to worsen over time and increase intracranial pressure. Our patient has symptoms and signs of elevated intracranial pressure like lethargy and vomiting. And our patient has reasonable neurological baseline, with a high likelihood that we will be able to reverse her deficits with our interventions. If you said all that, then you're my favorite person and you've won the House Cup. Your attending is not as effervescent as I am, though, and they are not at all impressed by the fact that you want to use an ICP monitor. Those attendings. They want to know right away what monitor you should use in her case. So, we've decided that a monitor is reasonable, but not all monitors were created equal. And this brings us to a discussion of monitor types. There are 4 major types of intracranial pressure monitors. Conveniently, they are named for the intracranial compartment from which they transduce the pressure. They are intraventricular, intraparenchymal, epidural, and subarachnoid. It's probably more accurate to say that there is intraventricular monitoring, and then there's everything else. Intraventricular monitors are considered the gold standard of ICP monitoring catheters. A hole is drilled in the frontal skull at a landmark known as Coker's point. An intraventricular catheter is then advanced through the frontal cortex, preferably the right frontal lobe to avoid injuring eloquent cortex, with the goal of placing the tip at the foramen of Monro. This will typically leave the holes located along the sides of the distal catheter in the frontal horn of the lateral ventricle. The drainage catheter is tunneled for a short distance under the scalp to help prevent infection. The catheter is then attached to the drainage line to the collection system. The system consists of a pressure scale, a drip chamber, and a collection bag. The system can be connected to a pressure transducer. And the drainage line usually has a few ports and stopcocks, which allow us to carefully collect CSF for analysis and even inject medications. Nice. We'll explain how the system works in a bit. So, the advantage of the external ventricular drain is that it allows pressure monitoring and CSF drainage. Kinda obvious. You are also able to sample CSF and administer medications intrathecally. But EVD is also the most invasive device. It penetrates the meninges and the brain, creating a potential path for bacteria and increasing the chance of intracranial infection. The longer the device is in place, the higher the risk. There is also a small risk of causing brain injury and hemorrhage during placement. We are talking 2%, but when it's the brain, that's a big deal. Also, an EVD is a tube system, and it is the nature of any tube system to get occluded from time to time. If you are choosing a device to only watch intracranial pressure, intraparenchymal monitors are a good alternative. Intraparenchymal devices consist of a thin cable with an electronic or fiber optic transducer at the tip that measures the local pressure. A small burr hole is still necessary to insert a bolt, which is screwed into the skull to provide a stable attachment point. The sensor can then be passed through a port in the bolt, which secures it inside at the correct depth. In general, intraparenchymal monitors are safer than external ventricular drains, as the portion that pokes into the brain is smaller and doesn't go as deep. It's only about 2 centimeters past the dura. This reduces the infection and hemorrhage risk significantly to less than 1%. Also, other monitors can use the same port and make direct contact with the brain parenchyma, allowing for some interesting diagnostics, like measurements of brain tissue oxygen tension. The disadvantages? An obvious one is that you can't drain CSF or inject medications intrathecally. Intraparenchymal catheters are also fragile and prone to mechanical failure, which causes a drift in the measurement over time for about 50% of patients. This may be difficult or impossible to quantify and correct. The overall accuracy is also always a question. We generally assume that the ICP reading at one point in the intracranial system adequately reflects the average pressure of the entire skull. We assume that because under normal conditions, CSF pressure should be in balance throughout the entire CSF space. With local pathology, such as localized edema, in reality you may have pressure gradients throughout the parenchyma, and your measurement may not completely reflect global intracranial pressure. Epidural monitors are optical pressure transducers that rest against the dura after passing through the skull. They are less invasive. The skull must still be open to pass an epidural monitor, but the dura remains intact and the brain is not exposed at all. What's the advantage? Significantly lower risk of intracerebral hemorrhage. We are talking 1/5 the risk of intraparenchymal and intraventricular devices. These monitors are sometimes chosen to monitor intracranial pressure in patients with extremely high risk of bleeding, such as liver failure, where coagulation factors are not being produced. Those patients also develop high ammonia levels, which cause significant cerebral edema, hence the need for intracranial pressure monitoring. Epidural monitors are also easier to place and tend to be less costly. So, with these advantages, why not use an epidural monitor for everyone? Well, the dura damps the pressure transmitted to the epidural space, which makes these monitors quite inaccurate. Finally, there are subarachnoid bolts, which are essentially hollow screws that can be placed through the skull next to the dura. For subarachnoid monitors, the dura is punctured. This allows the CSF in the subarachnoid space to form a fluid column, which touches the transducer placed in the bolt. There are no fancy wires here, just simple fluid dynamics. Just like the intraparenchymal monitors, subarachnoid monitors are safer than EVDs. These devices have low risk of infection and hemorrhage. But subarachnoid monitors are unreliable, often clogged with debris, and are less accurate. We rarely use these monitors. Back to the case. To remind you, this is a 54-year-old woman who was on anticoagulation due to atrial fibrillation and who developed diffuse subarachnoid hemorrhage, likely because of a ruptured right supraclinoid internal carotid artery aneurysm. She is becoming more drowsy and has evidence of early hydrocephalus. I return to you now and ask which monitor you would like to use in our patient's case. Quick! Your attending is waiting for your answer. Hopefully you said EVD in your head or under your breath. Just giving you the benefit of the doubt. Maybe it's because you know that with the diffuse subarachnoid hemorrhage, hydrocephalus is a common complication. The patient's clinical picture is also making you worried about her intracranial pressures, so you know you want to be able to divert CSF flow and maybe even clear some hemorrhage. We have chosen to use an EVD in this patient. It was placed through the right frontal lobe. Here are coronal and sagittal reconstructions of the CT angiogram, which coincidentally shows the path of the EVD nicely. So, EVD is in. Now we need to understand the mechanism of CSF circulation and how ventricular drainage works. We are about to adjust our EVD, so it helps to know what we're doing. How does CSF circulate? Well, take a look at this illustration of a patient in the sagittal view. For clinically relevant intents and purposes, the skull is a rigid, non-expandable box, and that box can be conceived of having 4 compartments: venous blood inside the venous sinuses and cortical veins that feed those sinuses, cerebrospinal fluid within the subarachnoid space and the ventricles, arterial blood within the intracranial arteries, and the brain tissue, the biggest compartment taking up about 80% of intracranial volume. Intracranial arterioles and cortical venules lie on the surface of the brain, and they are connected by a network of capillaries. Foramen magnum is at the bottom. The left ventricle contracts. The blood is ejected from the ventricle into the aorta, then ascends up the right brachiocephalic trunk, left common carotid, and left subclavian arteries. Then it ultimately arrives in the brain by means of the 2 internal carotids and 2 vertebrals. The systolic pulse wave carries blood into the intracranial vessels. Arteries are elastic and compliant, so they expand, and the blood flow slows down as it gets to the capillaries. At the same time, the pressure from the systolic pulse is transmitted to the entire brain and subarachnoid space. One of the main roles of CSF is to distribute and equalize intracranial pressure. The CSF wave then increases flow in the venous sinuses, and the venous blood drains from the head through the sigmoid sinuses and jugular veins. Slowed arterial flow eventually gets to the brain capillaries. Fluid exits the capillaries into the interstitium. There is a rapid diffusion and mixing of this interstitial fluid and CSF across the surface of the brain. It's really impossible to tell the difference between these two fluids. This model is based on a theory that is over 2 centuries old. It's the Monroe-Kelly doctrine. The amount of brain tissue cannot change. We can't suddenly lose a piece of brain. Which means the amount of arterial blood cannot change much either. The amount of arterial blood is largely defined by the amount of brain tissue that demands it. Also, the substance of the brain is nearly incompressible. So, in order to maintain a nearly constant volume of cranial contents, venous blood and CSF must be continuously flowing out to make room for the continuously incoming arterial blood. Now, say a patient suffers subarachnoid hemorrhage. Inflammation decreases compliance of the intracranial structures, especially vessels. Arteries don't expand as much during systole. They behave more like rigid tubes. The high pulse pressure is transmitted to the capillaries, and the CSF pulse pressure increases as well, and CSF absorption decreases. This increased transependymal stress causes ventricular dilatation, hydrocephalus. Now, add the external ventricular drain. It provides another pathway for intracranial fluid drainage, and with it, a way to dissipate intracranial pressure. In other words, it increases intracranial compliance, reducing the stress on the brain, meninges, and intracranial blood vessels. Okay, so we have an external ventricular drainage system in place. You just can't wait to start using it, but not so fast. First, we have to understand what pressure even means. Because of how physics works, pressure always has to be measured at one point relative to a reference point. It's a measure of how much the stuff in one compartment pushes against the compartment from which you're measuring. For convenience, we typically use the atmosphere as the reference point for physiologic parameters, but we have to choose the location of our measurements. For circulating fluids like blood, or in this case, CSF, you can treat the body like a container full of the fluid. We are water bags. If you have ever dove into a pool, using your ears as pressure sensors, you know that the pressure at the bottom of the pool will be higher than the pressure at the surface. So why do we only have one number for something like blood pressure? Well, to avoid massive confusion, people long ago decided that blood pressure would be measured at the level of the heart. And where do we measure ICP? Well, that's our old friend, the foramen of Monro, which is roughly at the center of the brain. But since most of us don't have X-ray vision, a more convenient external landmark corresponding to this point is the tragus of the ear. Now, if we go back to our system, we see that it starts with a 3-way stopcock. If you look more closely, you see that it's also aligned with the 0 on the pressure scale. And you will see a pressure transducer attached to a horizontal port at the same level. This is the reference point for all our measurements. So to have accurate readings, we will make sure that this stopcock is at the same vertical level as the patient's tragus. Okay, our system has been assembled and leveled. Before we try using the system, let's clear up a point of confusion. Intracranial pressure is usually measured and reported in millimeters of mercury to correspond with units used for blood pressure. But at many hospitals, the EVD system pressure scale is often set to centimeters of water. I guess the system will be filled with CSF, which is mostly water, so it is an easily understandable analogy. Since neurologists also frequently measure pressure in centimeters of water when performing a lumbar puncture, it may simply be out of habit. Let's first switch the pressure scale to centimeters of water. The drainage contains a short tube which leads up to a drip chamber, where the tube opens to air, allowing the CSF to escape. The level of this opening is indicated on the scale. Think of this like water spilling over the edge of a cup when it gets too full. We can make it harder for things to spill by making the cup wall taller, in this case by raising the drip chamber, or easier by lowering it. Again, because of how physics works, we can just treat the whole tubing system like a very skinny, oddly shaped cup, like a silly straw. It doesn't matter how many twists and turns and ups and downs the path takes. The only thing that matters is the level at which it opens to air. Other than that, the drip chamber just has some markings to allow us to measure how much CSF has collected. And there is another stopcock to allow us to empty it into a collection bag for disposal to prevent it from getting too full. Currently, our system is set at 20 centimeters of water. Let's say the patient's intracranial pressure is currently normal, about 10 centimeters of water. CSF drainage depends on the difference between the intracranial pressure and the pressure needed to exit the collecting system, which is defined by the height of the drip chamber. 'Cause, physics. If the patient's intracranial pressure is lower than the pressure set on the EVD, CSF will not flow. Look at the pulsating level of the fluid in the tube. Of course, these numbers are just an approximation to illustrate a point. ICP can transiently increase if a patient coughs, for example, so some CSF can get into the collecting system. Let's lower the collection chamber to 10 centimeters of water. Now the pressure in the chamber and the pressure inside the patient's skull are roughly equal. The EVD will act just like another ventricle. CSF is being produced at a rate of about 20 cc's an hour, and it will circulate through the intracranial ventricular systems and the subarachnoid space, and some of it will flow into the EVD at a rate of about 7 to 10 cc's an hour. This is why we place the EVD in our patient. When subarachnoid hemorrhage impedes intracranial CSF flow, we want to give CSF another place to go. Now, let's say a person's intracranial pressure rises. No problem. The patient's ICP of 27 centimeters of water is higher than the EVD setting of 10. This difference in pressures will encourage drainage, and the EVD will act like a pressure relief valve. Our patient has subarachnoid hemorrhage. This means that the blood will likely mix with CSF, and the viscosity of the fluid will increase, and drainage will become sluggish. Here is where lowering the drip chamber to 5 might help. It will increase the pressure gradient between the patient and the EVD, and hopefully it will help clear the blood in the system. By the way, because the collection system is a series of tiny tubes with resistance to flow, all of the CSF does not just immediately empty out if the system is dropped too low. But if we keep it too low for too long, we risk draining too much CSF, which lowers intracranial pressure. This causes a low-pressure headache because of the downward traction on the meninges, similar to the headache that happens after a lumbar puncture. In more serious cases, brain sags and bridging veins tear, resulting in a subdural hematoma. So be extra careful with leaving the EVD at too low a level. Now that you understand how the EVD works, let's get back to our case. In our 54-year-old woman who developed aneurysmal subarachnoid hemorrhage, likely because of a ruptured right supraclinoid internal carotid artery aneurysm, and who has evidence of early symptomatic hydrocephalus, she's getting drowsy, EVD has been placed. What is the most appropriate pressure setting for this EVD? Did you say the lower the better? So we want drainage of CSF and clearance of blood from the intracranial compartments. But a pressure setting of 5 centimeters of water may cause a large imbalance between the EVD pressures and the patient's intracranial pressure. This may cause a high rate of drainage. Aha! That's good, isn't it? Well, the high rate of drainage will cause decreased intracranial pressure. Yeah, and? But our patient has an aneurysm that has not been secured yet. Do you see where I'm going with this? Low intracranial pressure plus high arterial pressure within the aneurysm equals re-rupture and re-bleeding. So, in this situation, you have to be careful not to overdrain. Let's be conservative and set the drain to 15. Already, her EVD is outputting bloody CSF. But the attending is now twisting the main stopcock on the device, and you notice that the drain is already connected to the transducer. The CSF drainage stops, and the monitor begins showing pressure readings. Did you catch that? We can't measure pressure accurately if there is flow in or out of the system. It would be constantly changing. If you close the drain by rotating the main stopcock, the CSF no longer flows to the collection system. You effectively redirect the CSF pressure towards the transducer. The transducer is forming a wall for the CSF to push against, and the pressure of our measurement is how hard it's pushing. When the stopcock is rotated to allow flow from the patient to the drainage system, the transducer is blocked from the system completely. So, while you may see a number on the monitor, it doesn't actually mean anything. You have to manually stop drainage to get a single pressure measurement. With an EVD, pressure measurements are not continuous. That's all right, though, because if you've placed an EVD, that means your primary goal was to drain CSF and not to watch pressure. What happens when the stopcock is turned to allow flow from the drainage system to the transducer? Well, most likely it means someone has made a mistake, but if the system is working properly, it should read 0. Your attending is looking at you and telling you to interpret the waveform. Is the only increased pressure in the room from your attending's high expectations, or is something going on in your patient's head? This talk is about intracranial pressure monitoring, but so far we haven't done much of that. We have been figuring out how to use the EVD to drain. In all fairness, in our patient with subarachnoid hemorrhage, drainage is more important than intracranial pressure readings. But fine, I know, we promised. Let's talk about ICP monitoring. The intracranial pressure waveform has 3 peaks: P1, P2, and P3. P1, or percussion wave, is associated with the arterial pulsation. P1 is normally the dominant peak and synchronous with the systolic peak of the arterial blood pressure. P2, or tidal wave, is related to the increase in cerebral blood volume and the rebound of the blood pressure wave in the cerebral parenchyma. Basically, P2 reflects the elasticity or compliance of intracranial structures. The lower the compliance, that is, the stiffer the structures of the intracranial compartment are, the higher the rebound of pressure, and the higher the peak. P3, or dicrotic wave, may represent the aortic valve closure. It's basically synchronous with venous blood outflow. Why do we care about the waveform? Intracranial pressure is not a static value. It changes with cardiac contraction, respiration, and intracranial compliance. So, a single measurement of an average pressure every so often does not tell the whole story. What we really want is to estimate intracranial compliance, how well a patient's intracranial compartments can tolerate extra volume without a significant change in intracranial pressure. Or, better yet, we want to identify patients with poor intracranial compliance and intervene before they go off a cliff and develop intracranial pressure crisis. P2 reflects compliance. So when brain compliance decreases, P2 increases and becomes predominant over P1. And speaking of compliance, remember the Monroe-Kelly doctrine? the volume of brain plus CSF plus arterial blood plus venous blood should remain constant. If a patient develops a space-occupying lesion, there would be increased volume within the skull. And to compensate, there would be increased venous and CSF drainage. So, intracranial compliance is the ability of intracranial compartments to deal with this additional volume without a significant increase in intracranial pressure. Take a look at this graph of intracranial volume versus intracranial pressure. At physiological volumes and low intracranial pressures, small increases in volume can be compensated by venous drainage or CSF displacement. So, increases in volume result in minimal increases in ICP. Once this reserve is exhausted, a break point is reached. And at this point, even small increases in volume increases the ICP exponentially. But the reverse is also true. This is where small amounts of drainage result in large reductions in intracranial pressure. Now you know why we spent so much time understanding external ventricular drainage. So, intracranial pressure and intracranial volume are closely related. The other piece of the pressure volume story is autoregulation. At high volumes, a critical intracranial pressure level is reached, where it becomes impossible to pump adequate arterial blood to the brain. By the way, high intracranial pressures are not the only way to disrupt autoregulation. Regardless, we need to talk about autoregulation for a moment. Prepare for more graphs. You might remember that the neurovascular unit, or the component of the blood-brain barrier, autoregulates cerebral blood flow across a range of blood pressures. If the mean arterial pressure falls, arterioles dilate to maintain stable cerebral blood flow. Eventually, of course, the mean arterial pressure may become so low that autoregulation fails, and the brain is hypoperfused. This happens in acute ischemic stroke, where a blocked blood vessel interrupts blood flow. It's also worth mentioning that the entire curve shifts right for chronically hypertensive people. It makes sense because people whose brains are used to higher blood pressures should autoregulate at those higher pressures. For today's discussion, it is more useful to replace the mean arterial pressure with cerebral perfusion pressure. Interesting. The graph didn't change. That's because cerebral perfusion pressure equals mean arterial pressure minus the intracranial pressure. So, as the intracranial pressure increases and the mean arterial pressure remains the same, the cerebral perfusion pressure falls. And at low cerebral perfusion pressures, arterioles collapse and can no longer deliver blood flow to the brain, causing ischemia. So, intracranial pressure is important, but it's more important to focus on the cerebral perfusion pressure during treatment. If the normal ICP is approximately 5 to 15 millimeters mercury, and the normal mean arterial pressure in an adult is approximately 65 to 95 millimeters mercury, then the normal cerebral perfusion pressure is approximately 60 to 80. Of course, there's really no such thing as an average patient, and the optimal cerebral perfusion pressure is individual to each patient and each situation. Remember that the brains of chronically hypertensive patients are likely used to higher mean arterial pressures and therefore higher cerebral perfusion pressures. So these numbers function better as loose guidelines and not hard rules. That's why it's important to take the entire clinical picture into account. So, intracranial pressure and autoregulation are related. That's true. But speaking of taking the entire clinical picture into account, intracranial pressure is not the only variable that defines autoregulation. In our patients, subarachnoid hemorrhage may cause autoregulation to fail long before an intracranial pressure crisis sets in. Our 54-year-old woman with aneurysmal subarachnoid hemorrhage has evidence of early symptomatic hydrocephalus, and EVD is in place. She is less lethargic now that the EVD is draining. Her ICA aneurysm has not yet been treated. Look at her bedside monitor and tell me what you see. The top green line is the electrocardiogram strip. The white line is the intracranial pressure tracing. The red line is the real-time arterial waveform. Our patient has an arterial line. The blue line lower down is the oxygen saturation waveform. And the lowest yellow line is the respiratory waveform. Intracranial pressure reading is 9 to 10 millimeters mercury. Looking at the waveform, P1 is higher than P2, which is higher than P3. The monitor conveniently calculated the cerebral perfusion pressure for you, and it's 62 to 63 millimeters mercury. Thoughts? Yes! CPP and ICP are normal for now, and the ICP waveform implies good compliance. The most important thing now is to get that aneurysm under control, so the underlying condition can be addressed. The next day, our neurointerventional colleagues embolized the aneurysm by means of a flow-diverting stent. Now that the aneurysm is secured, the EVD was lowered to encourage more draining to help clear the subarachnoid blood. Our patient becomes more lethargic, which triggered a spot intracranial pressure check. Thoughts? ICP reading is 15 millimeters mercury, but that is deceptive. Look at the waveform. P2 is elevated as compared to P1. Uh-oh, that means the compliance of our patient's intracranial compartment is not great. This may be an early sign that intracranial pressure is about to rise. We need to do something about this. But what to do? How do we address our patient's decreasing intracranial compliance? Let's start with the basics. First, make sure your device is working. If the drainage path of the EVD is blocked with debris or a closed stopcock that shouldn't be closed, usually you will not be able to see a waveform. With partial blockages, a waveform may no longer look like the nice three-peak mountain that you're used to. Check the tubing to ensure that all valves are open and there are no obvious blockages in the catheter. The fluid in the catheter should be flowing or at least pulsating. If you're not sure, the easiest thing to try is to temporarily lower the drainage system. But wait. Because everything in the system depends on its height relative to the reference point. Once you start messing with the level of the apparatus or the patient, not only will the measured pressure be incorrect, but you could also alter the amount of CSF coming out. So, if you want to avoid any contentious encounters with an upset ICU nurse, don't touch the patient's bed controls or move the patient before talking to them. If it is still not draining, we need an urgent CT and involvement of our neurosurgical colleagues. Granted, I gave you all of those instructions so you understand what the next steps are to check, but you, the medical student, should never move the EVD settings without discussion with an attending and supervision. Hey, I have attending supervision. They're the one filming this.
Ah, sorry. Please continue.
In this case, the EVD is patent, plus the patient is showing clinical signs of elevated intracranial pressure. So if you see the ICP rising, you are definitely right to be concerned and need to intervene. Basic approach to an ICP crisis is as follows. Optimize head position to optimize drainage of venous blood from the head. This means that the head of the bed should be elevated to at least 30 degrees, above the level of the heart, and the head and neck turned to midline. If our patient were sicker and intubated, we can increase the ventilator rate slightly above what the patient is currently breathing to target a PaCO2 of about 28 to 30 millimeters mercury. Hyperventilation will blow off CO2, causing hypocapnia, which will cause cerebral vasoconstriction and reduce intracranial volume slightly by reducing cerebral blood flow. This is a temporary measure and will only work for a short period of time until you find something better. Remember, you are decreasing blood flow to the brain to achieve your goal, and it is easy to accidentally cause more harm than good. Also, once hyperventilation stops, CO2 increases quickly, which may cause a rebound increase in ICP due to extra vasodilation until the system corrects itself. A better intervention would be to start hyperosmolar therapy, like osmotic diuretic mannitol or hypertonic saline, to create an osmotic gradient that draws cerebral fluid from the brain tissue into the circulation. Basically, dehydrate the brain and make it smaller to create more space. We can also lower the EVD to promote drainage to shrink the ventricles. We can do those things without worrying about the aneurysm re-rupturing because the aneurysm has been treated. Next, remember that ICP is important, but more so due to its effect on CPP. Say our patient's ICP jumps to 40 and the MAP is 85. What would the CPP be? Right, 45. And that would place the patient at risk for, right again, ischemia. We can increase the MAP by administering pressors. Also, ICP may be increased by external factors like increased thoracic pressure. If the patient is coughing because they are bothered by the endotracheal tube or performing a Valsalva maneuver in response to pain, optimizing sedation and analgesia may be helpful. Sedation in general can also decrease metabolic demand, protecting the brain when supply is inadequate. Increasing MAP and lowering ICP may get the cerebral perfusion pressure into the optimal range. But there are limits. Your patient is deeply sedated. The brain is fully pickled, dehydrated, or shriveled. The ventricles are empty, and your MAP is about to reach unsafe levels for the heart. What happens then? We cheat. When all else fails, decompressive craniectomy, a procedure that involves removal of a piece of the skull, allows for more room for intracranial contents. Essentially, decompressive hemicraniectomy circumvents the Monroe-Kelly doctrine. The skull is no longer a closed box. Luckily, in this case, the patient just needed more CSF drainage. Residual blood was still gumming up the works. Within a few hours of dropping the EVD to 5 centimeters of water, our patient's lethargy has vastly improved. She is oriented to place, person, and time. Her headache and nausea have improved. The ICP tracing waveforms on the monitor are now consistent with high compliance. P1 is higher than P2. Cerebral perfusion pressure is staying in the above 60 millimeters of mercury range. Pat yourself on the back. You did it. On day 4 of admission, our patient spikes a fever of 101.5 Fahrenheit. Oh man, we just can't catch a break. There is no evidence of systemic infection. Chest x-ray and urinalysis show no acute disease, and blood cultures so far are not growing any organisms. Her lethargy is increasing again. How's intracranial pressure? Glad you asked. Waveforms are still high compliance, and CPP is currently 65. We need to repeat imaging. The repeat CT was thankfully stable. What is going on? What do we do next? Could this patient be experiencing a complication of the external ventricular drain? We reviewed the disadvantages of external ventricular drains earlier in this talk. Remember that EVD is an invasive device that penetrates the meninges and the brain, creating a highway for bacteria. So we have to watch out for intracranial infections like meningitis and ventriculitis. Thankfully, the rates of infection in a modern neurointensive care unit are very low as long as strict sterile procedures are followed and as long as the drains are removed as soon as they are no longer needed. If an infection happens, it most likely starts around 5 to 10 days after placement. The longer the device is in place, the higher the risk. The source of infection is either skin infection at the site of EVD placement, contamination of the system through the access ports, or hematogenous spread of some systemic infection. EVD-related meningitis and ventriculitis is considered a healthcare-associated infection, so you would be worried about gram-positive skin flora, like Staphylococcus species, and Streptococcus. The most common gram-negative organisms found in EVD-related infections are Acinetobacter, Enterobacter, Klebsiella, and Pseudomonas. The symptoms of EVD-associated meningitis and ventriculitis are the usual symptoms of intracranial infection. Headache, fever, and change in mental status are the top 3 symptoms that happen in over 40%. Nausea and vomiting are not specific. Focal neurological deficits and seizures generally don't occur until the brain parenchyma becomes involved. Neck stiffness only happens in 1 in 5 patients, so that's not going to help. Now, here's the problem. All these clinical features are similar to those of subarachnoid hemorrhage. So why are we concerned in our patient? I can think of at least 4 reasons. 1, she had intracranial hardware, the EVD. 2, she developed a fever. 3, there is no clear fever source. And 4, her mental status is declining without a clear explanation. By means of our EVD, we can draw off some CSF for analysis. You're typically looking for elevated protein, usually over 100 milligrams per deciliter, decreased glucose less than 40 milligrams per deciliter, although this only happens in 1/3 of patients. Glucose less than 10 milligrams per deciliter is even more concerning. And neutrophilic predominant pleocytosis, high neutrophil count. Here is another problem. Leukocytosis is not a sensitive finding, so a low neutrophil count does not exclude bacterial infection. Come to think of it, leukocytosis does not rule in bacterial infection either. If a patient has blood on their brain, they will also have white blood cells, like in our patient with subarachnoid hemorrhage. Bottom line, diagnosing EVD-associated meningitis/ventriculitis is challenging, but you do have to think about this complication because outcomes without treatment may be devastating. By day 6 of admission, our CSF analysis showed increased protein and cell counts, probably because of subarachnoid hemorrhage, but normal glucose. Fortunately, there is no bacterial growth on CSF and blood cultures. Intracranial pressures are normal and EVD drainage is decreasing. And our patient got an MRI of the brain with contrast, which showed no evidence of meningitis or ventriculitis. Fevers persisted for several days, but infectious workup was consistently negative and there was no infectious source. So this could have been a central fever induced by intracranial blood irritating the temperature regulation centers in the hypothalamus, a common finding in many types of brain injury, particularly SAH. In spite of all of this, neurologically, our patient is looking better day by day. Whew. Well, that was close. I'm glad she didn't develop an infection. Now, you are a little antsy after this infection scare. You know that the risk increases the longer the EVD stays in, and we never want to keep the EVD in for longer than absolutely necessary. Your attending asks, how much longer do you want to keep the EVD in? You wonder briefly if they know that you're a medical student and maybe shouldn't be making big calls about EVD removals and whatnot. But maybe it's also a sign of growing trust and respect, and you sure don't want to mess it up if it's the latter. And this brings us to the last part of this talk, EVD weaning. The when and the how. The timing of weaning is really defined by the underlying disease. If aneurysmal subarachnoid hemorrhage is the reason EVD was placed, you can estimate the timeline of hydrocephalus and blood clearance and time your wean accordingly. But no two patients are the same, and sometimes EVD weaning ends up feeling as much like the art of medicine as it does science. In general, you need 4 things. Your patient should be clinically stable for at least 24 hours or so. Intracranial pressures should be normal. Scans should show stable, if not improving, findings. Finally, drainage of CSF from the EVD should be slowing or stopping. This means that the natural reabsorption and drainage systems have started to function normally again, so you no longer need to patch the problem by diverting the CSF flow. Usually you're looking for a daily drainage of less than 200 milliliters per day. Nowadays, there is a significant body of evidence favoring a rapid wean. This usually involves raising the drain to a high level and ultimately clamping it. Then we assess if a patient tolerates living effectively without a drain. This means stable clinical exams, normal ICP measurements, and stable ventricle size on repeat imaging. The exact procedure for weaning will be dictated by each patient's individual situation. If the clamp trial is not tolerated, the EVD will be reopened and the situation reassessed in a few days. If a patient fails multiple weaning attempts, then we will likely need a long-term strategy for CSF drainage, like a ventriculoperitoneal shunt. But that's a topic for another video. What happened to our 54-year-old woman with aneurysmal subarachnoid hemorrhage and early hydrocephalus, which required placement of external ventricular drainage? Her ICP crisis was treated. She stabilized, allowing for EVD weaning attempts. It took some time, but her EVD was clamped and ultimately removed. And she was discharged without significant lasting focal neurological deficits. Here is the progression of her hydrocephalus. Early hydrocephalus before the drain was placed. The hydrocephalus initially worsening during weaning trials. And ultimately improving on the final scan. And that's all for today. While I'm here, I'd like to thank the Academy just for the nomination, and I'd like to thank my parents for endlessly supporting me through all of the acting. Oh wait, I'm becoming a doctor. Well, I guess I'm graduating, so I'm not sure if there will be a next time, but if there is, I'll see you then. Bye.